Remember, when one person does it, it can be done. It just requires a little application of mind. So how do you monitor a patient on a ventilator? See, we generally look at the clinical signs, ABG, pulse oximeter, capnography, chest X-ray, CT scan, bronchoscopy, all fine. But there are the ventilator, the one person does it, it can be done. It just requires a little application of mind. So how do you monitor a patient on a ventilator? Some sound is coming, Saneesh. ABG, pulse oximeter, capnography, chest. Yeah. Using the ventilator as a probe of physiology to monitor the respiratory mechanics. The tube you put sends in the air. It's like if you compare it to an ultrasound machine, there you give a ultrasonic waves. Here you are giving a air, and there is airways and tissue, or the alveoli, and it reacts with them. And the information what the ventilator gets back is what is displayed as scalars and loops. So, and this is there all the time. It's not like an X-ray. You do an X-ray in the morning. At midday, there is a deterioration. You can't do an X-ray at midday. And if there is a deterioration in the evening, you can't do a CT scan in the evening. So the loops and scalars are a real time looking at the how the lung is behaving. In the course of next 20 to 40 minutes, probably I'll try to convince you that you are not looking at lines. You are looking at your airway and your alveoli through those lines. That's the what I'm going to try to convince you. What you are going to look at are not just lines or loops or curves. It is there is information about your airway. There is information about your alveoli. You just have to know what you have to look at. See, if you compare between a lung ultrasound and a ventilator, the endotracheal tube is like a probe, and the ultrasonic waves is like the air going through. Now it meets the tissue and you get images. Here you get the graphs, and that if you know how to analyze, you know the pathophysiology of the lung, and it's real time. That's the beauty of this. You don't require to repeat a CT scan, or you don't have to shift the patient. It is always on the ventilator. You just have to know what to look at, and you always get excited if you do an ultrasound. There is a lot more information that you can get out of the loops and scalars if you know what to look at. So yesterday we went through this, isn't it? Ventilator just generates an inspiratory flow of gas, and when a flow is given for a time, it becomes volume. The whole purpose of mechanical ventilation is to push a volume into the lung, isn't it? Flow and volume are same. When flow is looked in the context of time, it becomes volume. So a flow starts from the ventilator because we know we fix the I time, or the patient fixes the I time on his own. Then the volume is spoken as a tidal flow is spoken as a tidal volume. The flow and volume are same. When the flow is spoken in the context of time, it becomes a tidal volume. And this we have seen yesterday also. Alveoli is a cul-de-sac. So whenever you put a volume into a closed space, what increases? I've told you pressure increases. So there are three components now. There is a flow. When flow is looked in a context of time, it becomes volume. Then in a closed space, it generates a pressure. These are the two pressures we are going to discuss. We have discussed the driving pressure yesterday. Dr. Saneesh, my colleague, has extensively discussed this, and these two pressures are going to be discussed in every ARDS, COPD, whether we talk of organophosphorus compound poisoning, whatever, these two pressures will be spoken of. Now, what I want you to understand is, what is this pressure we are speaking? We are speaking about the alveolar pressure, or the pressure that this volume, when it gets into this closed space, produces a pressure. And studies have proved that pressure, that plateau pressure, if it is less than, it has to be maintained less than 30 centimeters, and a driving pressure of less than 15 centimeters is a safe zone for preventing ventilator-induced lung injury. So there are three components now. Flow in a context of time becomes volume. Volume into a closed space becomes pressure. So in the end, what you have to understand is, when a flow starts from a ventilator, becomes volume, gets into the alveoli, three components are generated: flow, volume, and pressure. And the whole essence of mechanical ventilation is to place a volume into the lung, isn't it? That's the reason why we put a patient on a ventilator. Now, every breath has three components: flow, volume, and pressure. I made that slide for you to impress upon you why only where there are flow versus time scalar. Somebody may think, why flow versus time scalar is there? Why volume versus time scalar is there? Why pressure versus time scalar is there? That is because when a flow occurs and a volume generates into the alveoli, these are the three components that matter to us. When volume starts interacting with the airways and the alveoli, these are the three components we come to look at. So we plot this in the vertical axis, the y-axis, flow, volume or pressure, one at a time, and time is always in the x-axis. So those are called scalars. When you have only one parameter on the y-axis with time, it is called scalars. And you should understand here, when you talk of flow, that means you are talking liters per minute and it's only flow. You can't look at volume and pressure in a flow loop. And if you are looking at a volume, you are looking at tidal volume. If you are looking at flows, you are looking at peak inspiratory flow, peak expiratory flow, or how the flow is starting when the patient is trying to breathe, something like that. When you look at the pressure versus time, you can look at all your peak pressures and your driving pressure, plateau pressures, and things like that. So what I want you to understand at this stage is, first analyze what is the scalar you are looking at. Scalar is one parameter in the y-axis with time in the x-axis. And if you are talking, once you make a decision that you are looking at pressure, you will be looking at only pressures. There in a pressure versus time scalar, you can't look at the loops, or you can't look at the flows, peak inspiratory and peak expiratory flows, or you can't look at the tidal volumes. So that much clarity you should have when you try to understand. So there are three scalars, and scalars are one parameter on the y-axis with one on time on the x-axis. Then there are something called as loops. We have said that the whole essence of mechanical ventilation is to push a volume. So volume should be there. When you are analyzing, it doesn't make sense if you don't have volume as one component. So once you fix that volume is one component, then there are only two other components. So there can be only two types of loops: volume versus pressure. Volume, we call it as PV loops or FV loops, flow versus volume. These are the two loops that we get, and these are the loops. They look like this, where pressure is on the x-axis, volume is on the y-axis for a PV loop, and for the flow volume loop, there is on the x-axis a volume, and on the y-axis there is a flow. And another thing that you have to notice is, whenever there is a flow component, there is a representation below the baseline. You see here, there is a representation below the baseline. So these things, if you remember basics, that whenever there is a major representation below the baseline, the component of flow has to be there. Either if it is a scalar, it will be flow versus time scalar. If it is a loop, you can boldly say that it is a volume flow loop. This much is understood. So we have scalars and loops, and these are the three scalars, and these are the two loops. These are PV loop and FV loops. And scalar, as I've said, whenever there is a major representation below the baseline, and scalars always start from one point and move towards the left. They never come back to the point of origin. Whereas if you look at your loops, the loop always starts and comes back to the point of origin. All the loops has to come back to the point of origin. If it doesn't come back to the point of origin, you can be rest assured there is a pathology when you are looking at the loops. But when you look at the scalars always start from one point and move towards the right. They never come back to the point of origin. And as I said, whenever there is a representation of any wave, major representation below the baseline, it is always flow, flow, flow. You remember that. See, when you are standing 10 feet away, if you look at your ventilator, if there is one wave with a major representation below the baseline, you should say that is a flow versus time scalar. And in a loop, if there is a representation below the baseline, you can say it is a flow volume loop. So these are the things generally you can find out with your flows: auto-peep and modes and secretions. And if it is pressures, as I have said, peak pressure, plateau pressure, dynamic driving pressure, and compliance can be estimated with this. And volume, as I have said, flow and volume are same. Only when it is looked in the context of time, flow becomes a volume. Only leaks can be made out with volume. And in fact, volumes are not measured. It is always estimated from flow. Flow, and with the context of time, the ventilator estimates. So generally, this is not nothing much to look at this. Only once you know how to identify a leak, probably there is nothing much to learn. So the whole scalars will round up with flow versus time scalar and pressure versus time scalar. We'll go with one by one. Flow versus, we have looked very extensively learning about the modes yesterday. All that yesterday I taught was flow versus time scalar. Flow versus time scalar. You can look at the patterns of breathing. This square wave is always what? I've told you yesterday, when there is a constant flow, you get a square wave. A square wave always indicates a volume ventilation. A decelerating flow is always a pressure. It may be pressure support or pressure control. And one more thing you have to notice here, the difference between pressure support and pressure control. This is a flow cycle one. This doesn't touch the baseline. If this is 100% flow, when it comes to 25% of the flow, it changes from inspiration to expiration. This is the only mode where patient can start the breath and cycle the breath. This is pressure controlled. The difference is it touches the baseline and then the expiration starts because it is time cycled. So it has to touch the time one. But whenever you say it is a pressure mode, you remember there will be a decelerating flow. This is how it looks. When you stand somewhere and if you see a decelerating kind of a flow versus time pattern, you should know it is a flow, some pressure mode. That is, you should be your analysis. When you see a square mode, you should say the patient is on a volume mode. And physiologically, when you breathe, it will be a sine wave. This is how it looks. So, inspiratory pattern, this you have already seen. This is flow versus time. See now, there is a representation below the baseline. Whenever there is a representation below the baseline, this is a flow versus time scalar. And because it is a square wave, what is the mode I am using here? What is the mode? You can all type. It is constant flow. It is a volume ventilation. So this is the trigger phase. The ventilation has to stay. So patient is on a volume mode. So the patient, it is a time cycle. Ventilator has to start the breath. So expiration valve closes, the inspiration begins. This is the peak inspiratory flow rate. So we are speaking of flows now. So everything is flow. This is the cycling phase. The set volume is delivered. It's volume cycling or time. Then expiration valve opens and the expiration starts. This is the inspiratory time. This is the expiratory time. And if you come back here, obviously this has to be peak inspiratory flow rate. And this is the one cycle time. If I have a rate of 10 and a E ratio of 1:2, this will be 6 seconds and this will be 2 seconds and this will be 4 seconds. Because time is there, this will be represented by time, you can definitely find out. So this is flow versus time. So these are the things you have to look at. If somebody has a obstruction, what will happen? Probably this will go for a long time. Its expiration will be prolonged, or probably if there is auto-peep, it will not fully empty and the expiration will start from here. So these are the things you have to look at the expiratory limb and find out. In the next 2-3 slides, I'll show you. See, this slide we have discussed. I'm just putting it again to revise that there are two trigger variables. One is patient. Only two people can trigger, patient or the ventilator. But if it is the patient, it is always time. If it is the patient, what are the two types of triggers we discussed yesterday? One is pressure trigger, then the other one is flow trigger. Then there is a problem with the flow here. In a volume controlled ventilation, there is a fixed flow. So there is a lot of asynchrony or dysynchrony when the patient tries to breathe. Whereas with the pressure modes, it's more adaptive to the patient. Then when we come to limiting, only ventilator can limit. It's by volume or pressure limiting. Once you can say to the ventilator, either give a flow till 400 ml or 500 ml is delivered, or you can tell the ventilator, you pressurize the circuit till the pressure of 25 centimeters or 15 centimeters, whatever you said is achieved. then the flow stops or the flow decreases once the pressure is achieved. So limiting is always done by the ventilator, and cycling, the change from inspiration to expiration, all modes is done by the ventilator, and it's mostly by time. Only one mode, which is called the pressure support mode, by full flow cycling will occur where the patient can control two modes, and that is the beauty of that mode. That is the reason why almost 50 to 60% of the time a patient spends on a ventilator would be on a pressure support ventilation. This is just to reinforce that by knowing the flow versus time, it gives you a concept to learn the modes. That's what I'm trying to tell you when I'm discussing this with graphics. So it is a flow versus time. Now look at now what has happened. Now what has happened? See, let us analyze. The peak expiratory flow looks all right, but the time for expiration has become more, and it is not completely emptying. So something has stayed back. What do we call this? Dynamic hyperinflation, auto-peep, isn't it? This is how you find out on a flow versus time scalar. If it doesn't touch the baseline, we call it as a auto-peep. If it happens from here to here, if this is more distance, then there is more auto-peep. So you remember this. And if this has serrations like this, probably it indicates secretions. Or if you are using a humidifier and if the circuit has lot of water particles on the circuit, you may get something like this. This always indicates there is some obstruction for the expiratory air, and that the ventilator senses. It may be inside the lung or outside the lung, but when it starts hitting, it doesn't have a smooth flow, then these serrations appear, and that is indicative of secretions. You remember these two. These two are important, and these are the only things that you can reasonably make out on a flow versus time. These are the two. One is auto-peep, one is secretions. Look at here, what is there? There is a decreased peak expiratory flow, and it is prolonged. I have sensed it's taking too much time, the expiratory flow is not adequate. I have given something to the patient. Now the peak expiratory flow has increased and the expiratory time has decreased. What I have given to the patient? Understood? It should be a response to a bronchodilator, or probably a good suctioning also would do this, isn't it? If there is a obstruction, it has been relieved. The obstruction has been relieved. So the peak expiratory flows have increased and the expiratory time has shortened. So you can also look at the effectiveness of bronchodilator therapy by looking at your flow versus time scalars. So understanding modes, this we have gone through yesterday. Here both the modes are all the three stages: triggering, limiting, cycling. This is volume control, this is pressure control, are all controlled by the machine, and there is just triggering. It is not to be seen on this flow versus scalar. I have just put it for your impression. This is always visible because it is below the baseline, a drop in the pressure on a pressure versus time scalar. I have just put it to impress upon you. This is how it looks if you are looking simultaneously with pressure versus time. So these are again volume and pressure assisted ventilation, nothing different, but one part of the cycle has been given to the patient. But my advice is, whenever you have a patient starting or trying to breathe, this mode should be changed to this mode. I will tell you how to shift and how to set the pressure in the next subsequent slides. You just remember, this is not a very good mode for patient to breathe because it's a controlled or a fixed set flow. This is not adaptive to the patient's the way he breathes. So then you have to shift from pressure control to a volume control to a pressure control. Then this is the third mode where two phases are in the patient, and that is the only mode which we have discussed is the pressure support mode. Yesterday there was some confusion. Everybody were asking that it was not demonstrated what is expiratory sensitivity. By default, as I have said, it is always fixed at 25%. 25% trigger sensitivity. That means if my peak flow is 40 liters, If my flow starts decelerating and I come to 10 liters, that is 25% of 40, I change from inspiration to expiration. If I change this to 50%, when the deceleration starts, when I am at 20 liters only, I start from inspiration to expiration. That's how you change the IE ratio. Another way of changing is this P ramp. It is called P ramp. It is nothing but it is when you increase this, the flow increases. As I've shown the bucket yesterday, if you increase the flow of the bucket, your bucket fills faster. That means if you increase the inspiratory flow, the tidal volume is given in a shorter phase. These are the two things that you can manipulate on a pressure support mode, where you can change the inspiratory time and the expiratory time. These are the two things I'll show you. There is something wrong in this. What is wrong in this? You look at the trigger. See, F and P, there are two triggers here. You can either choose a flow trigger or a pressure trigger, and I've said and I've told you repeatedly yesterday that it should be how much? It should be 1 to 2 centimeters of water. Because it is a flow, it should be 1 to 2 liters per minute of flow as a trigger. This trigger is high. You should set the trigger. See now, see this good amount of inspiratory time is there. You see it is 25%. I changed it to 50%. You see, I've changed it to 52%. I've shifted the trigger also. You look at the inspiratory time. You look at the expiratory time. You look at the inspiratory time here, and you look at the inspiratory time here. The inspiratory time is much shorter here, because I've shifted the expiratory trigger sensitivity. Because you see where it is happening. It is deaccelerating here, and when it comes to 10 liters, it is cycling. Here it is coming to 20 liters, it is cycling. This is how it works. If you want to change the inspiratory time, the two parameters in a pressure support you can change is, one is expiratory trigger sensitivity, or the P ramp. P ramp is nothing but increasing the flow. This part, I think a lot of people were sending some questions to me. I thought I would just clarify. I hope I am very much clear on this part. If any doubts are still persisting, you can ask me now. I am sitting on pressure support because 70% of the time a patient spends on a ventilator is on pressure support. You should know how to use pressure support. And I have said that, see, there is no tidal volume. Pressure support is here. You look at the volumes. If the volumes are adequate, if volume is 300, you want 400, there is no volume button. You have to increase the pressure support from 12 to 15. That's how the tidal volume is managed in a pressure support mode. The IE ratio and respiratory rate are left to the patient, but you can manipulate to an extent by changing these two parameters. Am I clear? I hope I'm clear.
Sir, like two doubts are there, sir. One is like, if we increase the expiratory trigger sensitivity, does it change the respiratory rate?
Yeah.
That is one question.
No, respiratory rate may change, because if he is a COPD patient, and if you shorten the inspiration, and if you give more time for expiration, if he blows out carbon dioxide, probably the rate may settle down.
But there is no direct effect on the respiratory rate.
It is an
indirect effect only.
Yeah, it is an indirect effect. The rate is controlled by the brain of the patient. It cannot be controlled by the ventilator. But when, for example, in a COPD, if you shorten the inspiratory time, if the IE ratio, which was 1:2, becomes 1:4 now, probably he'll blow out carbon dioxide, rate may settle down.
There are other question is like, what are the different scenarios where you have to change the expiratory trigger sensitivity?
No, we will get into that when we talk of COPD and other modes.
Other people are asking about P ramp, how the P ramp changes, and again what the difference?
P ramp is, you have to look at your the manual you get to the get along with the ventilator, because there is no standardization. The ramp is entirely different. When you say the ramp increases from 70 to 150, if you look at the manual, it will say the peak flows increase from 40 liters to 60 liters. It is different for different ventilators. You can look at your manual. It will be clearly given. At 70 milliseconds ramp, what will be the flow? At 80, 90, 100. It is different for different ventilators. It's nothing rocket science. If you increase the P ramp, the flow increases. That much if you remember, you look at your manual of your ventilator, what you are using, probably you will know. See, this is what happened there. This is what happened there. See, the inspiratory time, which was this much, became this much. The expiratory time, this time went in for expiration. This is what I have done there. And then this is the rise time. You see the amount of time it is taking to reach this point. The flow is very slow. Now you see how fast it is reaching, how fast it is reaching. You look at what is happening to the inspiratory time here. So this is how it will happen, so that inspiration is finished. It is obvious, isn't it? When you increase the inspiratory flow, the tidal volume is delivered at a shorter time. You remember that. Don't get into too much of P ramp, things like that. The science behind it is, if you increase the P ramp, flow increases, the tidal volume is delivered in a shorter time, more time is left to expiration. These two things are altered in mostly COPD patients. So what is this mode? Just another example for looking at the modes. This is a square wave. So it has to be volume controlled, decelerating, touching the baseline, time cycle. So it has to be pressure controlled, happening much above flow cycling. So it has to be pressure support. See, there is a pressure controlled and a pressure support mode side by side. So when there are two modes in a breath, in a 1 minute, so it has to be obviously SIMV. This is not volume control, sorry, a mistake. It should be pressure controlled with pressure support breaths. So it is a SIMV, pressure SIMV, pressure controlled SIMV. The mandatory breath is pressure breath, and pressure support breaths are where two phases are controlled by the patient. Here only one phase is controlled by the patient. We in fact discussed yesterday that this is not a very good mode, because the diaphragm is going to contract here. Diaphragm is going to contract here. It's not going to keep quiet. I said that if you want to shift from a volume mode to a pressure mode, how do you shift? See, when the patient is on a preset pressure or a square wave, and the patient starts breathing, patient has started breathing, you want to put a pressure support or a pressure support or a pressure control. You do a plateau pressure. And if the plateau pressure is 15, at that plateau pressure, if he is getting 450, the pressure control level here should be 15 centimeters, or your PS should be 15 centimeters. That is the pressure that is required to generate this volume. That is what you have to understand. So when you are shifting from a volume mode to a pressure mode, you do a plateau pressure and check the plateau pressure. That should be your pressure control or a pressure support in a pressure mode. And I have told you, it's a fixed flow. It's not very comfortable to the patient. So this mode should be used only when the patient is passive, not meaning that he should be paralyzed. Lot of patients can be kept passive by good sedation. And there are many conditions like GB syndrome, OP poisoning, where the patient is passive by himself, isn't it? So there are indications in a sick KRDS. Volume controlled ventilation is what we generally do. So this is again volume ventilation. This should both are pressure ventilation, pressure support and pressure control. When you shift from volume to pressure, do a plateau pressure and look at the pressure, and that should be the set pressure here. It should not be unscientific. You should not start putting at 8, 9 and go. Patient will hyperventilate. We already know what is the patient and we are happy with the tidal volume. You can generally shift this pressure here and the patient will start ventilating with this volume. So pressure, next 7 or 8 slides are very, very important. I urge that you remember these slides, because this is what is going to save your patient. So all of you concentrate. Now, this is the pressure wave. Now we are looking at pressure or sustain. There is no flow component. So everything is pressure. This is PEEP. This is peak inspiratory pressure. And if you put a inspiratory volt, what you get is a driving plateau pressure. The difference between plateau pressure and PEEP is driving pressure. So everything we talk is pressure now. So because it is a pressure versus time. Pressure versus time. So this is PEEP, this is the TI and TE, this is the peak inspiratory pressure. So these are the two pressures we are very interested with. So let us learn how to get this pressure, plateau pressure. And we told yesterday plateau pressure is a surrogate of end inspiratory alveolar pressure. I will show you a graphic for you to remember. You remember when you put an inspiratory hold of 1 to 2 seconds. See, this is the button. This is the most important button on the ventilator. You should know the inspiratory hold. And inspiratory hold of 1 to 2 seconds, you get something. The pressure decreases because there is no flow. There is some redistribution of the volume, and you get a P flat. This is called plateau pressure, and we have discussed that it is a surrogate of end inspiratory alveolar pressure. The difference between PIP and plateau is called airway, trans airway pressure. The airway contribute to this pressure. If there is any problem with the airway, this increases. If PIP is 40 and plateau is 20 centimeters is going for driving the volume here. So that is purely a resistance problem. If PIP is 32 and plateau is 29, so there only 3 centimeters is required to push the air here, and the rest is going to alveolar. So when you see a graph like this, you are not seeing lines. That is my point. You are looking at airways and alveoli. So if somebody asks you, are you seeing some alveoli and airway? You should say, yes, I can see my patient's airway and alveoli through my graphs. That is what I want to impress upon you and make you understand. There is so much of information you can get so that you know whether the problem is airway or the problem is alveoli. The difference between plateau and PEEP is called the driving pressure, what my colleague Dr. Saneesh has discussed yesterday. There are some limitations that patient treats the lung as a single unit. We don't know, we'll not get into that too much controversies. I'll be discussing all these pros, cons when I talk about ARDS ventilation. And obviously you cannot put an inspiratory hold when somebody is breathing, isn't it? So patient has to be passive, not necessarily paralyzed. Patients can be passive with good amount of sedation. So what I want you to understand here is the difference between PIP and plateau is contributed by the airway. The difference between plateau, P flat or P flat is the static the volume that the alveoli push to is P flat, and the dynamic pressure that is applied to each volume of each tidal volume that is being pushed is the driving pressure. So that is the reason why nowadays we are thinking of looking as a dynamic pressure, which is more of in the terms of driving pressure. But as I told you yesterday, driving pressure, the only paper is by statistical analysis. It is not a direct randomized control trial. Many of them are happening. You'll get to know. But this science looks good. I think it will show that driving pressures will be applicable. So there are 3 pressures. One is PIP, plateau, PEEP, and driving pressure. These are the pressures you should know when you put an inspiratory hold. And how to analyze, I'll put one or two case scenarios and you will know how to do it. See, when there is no flow, what is the flow communicating with? Flow is communicating with the alveoli that are open. So once you put an inspiratory hold, there is no flow, there is no air, fresh air flow, but there is an air column, and this air column is communicating with all the alveoli that are open. The ones that are closed are not communicating. So you get a pressure of the alveoli that are open or of the baby lung, and we are interested to safeguard the baby lung, isn't it? You remember this. When there is no flow, the air column is communicating with all the open alveoli. So the pressure what we get, the P flat, is indicative of a end inspiratory alveolar pressure. That is what I want to impress upon you. This is the alveolar pressure, that what we are getting out of the inspiratory hold. See, the most important button on your ventilator, I would say, is the inspiratory hold if you are ventilating a sick patient. So it is always preferable to do it on a volume controlled mode. Patient has to be passive, and this timing also is important because recent studies have proved if you do it for a long, the driving pressures come little less. Within 1 to 2 seconds, if it is 25, if you give it to 6 or 8 seconds, it may come to less than what you estimated at the first 2 seconds. So the studies have proven that it should be done only for 1 to 2 seconds. So it is there in every ventilator. Go find where it is, and you just have to press it 1, 2. and the patient has to be in a volume control mode, you get the plateau pressure. It will be displayed like this. See, I put an inspiratory hold and this will display. The peak is 30 and the plateau pressure is 24. This is how you get it. This is how you see it should be on a volume controlled mode. So yesterday Dr. Saneesh was discussing this. I just want to add up one more. See what has happened here. When I increase peak, the plateau has gone up, and here the plateau has come down. At the alveolar level, what is your concept? This is about recruitment. See, this pressure adds up more alveoli, new alveoli. The same tidal volume goes to more alveoli. Obviously, the pressure falls. We call this as responders. And if the alveoli all get over distended, the plateau pressure goes up. This we call it as non-responders. So this is important because when you do any change in the peak, if the pressure goes up, plateau pressure goes up, what you should understand at the alveolar level is happening is your baby lung is over distending. We don't want this to happen. This is a red sign because it goes into biotrauma and it becomes a multi-organ dysfunction. VAL, volutrauma, atelectotrauma, biotrauma, and if you are very good, you may induce a barotrauma also, isn't it? So obviously, a plateau pressure is indicative of what is happening at the alveolar level. I want you to conceptualize that if the plateau pressure goes when you increase either the tidal volume or PEEP, this is what is happening to the baby lung. If the plateau falls, you are recruiting or opening up new alveoli. These patients survive better than these patients. This is what you have to visualize when you are standing and doing these maneuvers in front of the patient. As I've said, see the difference between PIP and plateau. So this is always a airway problem and this is always a compliance problem. See, these are the plateau has gone up. This is contribution of the airway. This part is the contribution of the airway. Look at the contribution of the airway here. So huge. I've shown you the figure. The airways will be here and the alveoli will be here. So alveoli is not doing much. The whole contribution is by the airway. And here the whole contribution is by the alveoli. See, compliance estimation, compliance is nothing but tidal volume divided by this. See, if somebody has a 500 ml and you don't have to calculate this. Once you do a plateau, all the ventilators give the compliance on their own. You just have to push that button. You just push that button, the compliance and plateau pressure are displayed in all ventilators. So you don't, but if you still want to remember, you can remember. See another example. So if you get a compliance of 34 and 50, so probably this patient has a better lung compliance. He'll survive better. This is a non-responder probably, and this guy will respond to your maneuvers. This is how you analyze. And these are some of the values. Normally, compliance is 100 centimeters of water. In ventilated patient, it is 60 to 70. If it is 40 to 50, 50 to 40 centimeters, we call it as mild injury. Less than 40, it is moderate ARDS. If it is less than 30, we call it as severe ARDS. See, the lung will be like this. See, once you get and if you do plateau pressures, probably plateau will be 25, around 29, 30 or 30, 32 when you try ventilating this. So all these are correlating. All they are related. The same parameters are used to estimate every pressure, the driving pressure, the plateau pressure, then your compliance, everything utilizes the plateau pressure. The end alveolar pressure is used to estimate all the pressure. So plateau pressure is important. That's why I said that is the most important button that you should be knowing in your ventilator. See, this is knobology. Don't try to ask me where is your button. You go and find out, or call your application specialist. He will come and teach you. Just press it for 1, 2. Just count 1, 2. Just press and leave. The plateau pressure will come. Then in the future ventilators, even the driving pressure comes. Driving pressure is nothing difficult to estimate. Once you get a plateau of 30 and if you put a PEEP of 15, the driving pressure obviously is 15 and the compliance will come on its own. If the compliance is more than 50, you obviously know the lung is not going to trouble you. You don't require to do a ABG, you don't require to do a X-ray. You can just cut down your FiO2 after intubation and tell the nurse, if he starts breathing, you put him on a pressure support. See, what I'm trying to impress upon you is there is so much information about the airways and the alveoli. You just have to know what to look at. and you can ventilate the patient without doing unjustified ABGs. I've seen 4 ABGs when the patient is normal, 2 X-rays, a small deterioration, X-ray is done. That's not the way you can ascertain what is the problem and do a lot of correction if you know the graphics very well. See, one case scenario is 40-year-old diabetic admitted with a respiratory failure of SpO2, 85% on 15 liters of oxygen, non-breathing mask, drowsy, BP is low, heart rate is high, increased workup breathing. Do we intubate or NIV? Dr. Arjun?
Intubate, sir, intubate.
Yeah, good. See, this is not a good candidate for NIV, isn't it, Arjun? Why you want?
Yes, sir.
Why you want?
Because the patient is not conscious, sir, so he not put on NIV.
Yeah, good, good. Even the blood pressures are 90/60. There is already is getting 100% oxygen, isn't it, on a rebreathing mask?
Yes, sir.
Yeah. So these patients are better to go, and as you said, this is the clinching factor.
Yes, sir.
Yeah. Which mode? I've intubated 7 ml per kg trial volume. FiO2 is 100%. IE ratio is 1:2. Respiratory rate is 20 and PEEP is 5. What is the pressure that is readily available on the ventilator? Peak pressure, isn't it? It is displayed.
Yes, sir.
So now peak pressure is 22 centimeters. What do I do? What does it tell you? Peak is 22. Your lung is good or bad?
Bad, sir, bad.
Peak,
Bad lungs, sir.
Peak pressure of 22, not the plateau.
Sorry, sir. Hello.
The peak pressure is just 22 centimeters of water. The plateau is always less than peak, isn't it?
Yes, sir.
So reasonably, this lung is good, isn't it?
Yes, sir. Good lungs.
So you just know that the lung is good. You reduce the FiO2. You don't require to do an X-ray. You don't require to do an ABG, isn't it? So you know that your alveoli is good. Yes or no?
Yes, sir.
Okay. I do an inspiratory hold. You just forget this now. I just do an inspiratory hold. If this is the scenario, my P flat is 35. Is my lung good or bad?
We are the alveolar pressures are more, sir. We are destroying the alveoli with peak with P flat of more than 35.
No, for the settings we have done, P flat is around 35 and peak is around 37. So obviously it is causing VILI. That much
Yes,
is understood now. So what do you do?
Sir, we will give you the bronchodilators.
See,
Bronchodilators.
why bronchodilators? Look at the trans airway pressure 38 and 35. Only 3 centimeters of water is the trans airway pressure. So there is no airway problem.
Yes, sir.
Nebulization is something which is done very, very unscientifically. So this guy doesn't require nebulization because his peak is 37 or 38. So only 3 centimeters is required to push the air through the airways. So it is plateau is 31 and driving pressure is 26. So lung is collapsed. So what should you do?
Reduce the volume, sir.
From 6, then if it's not working 5, and you can increase the PEEP to 10 or 12 and watch, isn't it?
Yes, sir. Yes, sir.
So this is how you have to work. You don't require X-ray for this. You don't require ABG for this. Everything, all the information is available on the ventilator. That is what I'm trying to tell. When you are working, if the surge occurs, when you are working in a periphery, there are too many COVID patients. You just look at your plateau and driving pressure. You can start reducing your tidal volume, increasing your PEEP. See, whenever you decrease this or increase this, you again reassess after 5 minutes the plateau pressure. It requires 5 minutes for the PEEP to work. There are studies to that effect. Yesterday, somebody was asking a question. How often do I change PEEP? How do I do a plateau pressure? I wait for 5 minutes after a change in volume or a plateau and change in the PEEP or a tidal volume, then do a plateau. Now the plateau has become with this 5 ml, say 29 and at 10 PEEP. Are you happy?
Yes, sir. Yes, sir. Yes, sir.
That is how you work, isn't it?
Yes, sir.
That is what I want you to understand. It's
Okay.
a ARDS issue. Trans airway pressure. Probably, if as you said, if the trans airway pressure is so high, then you may require nebulization. Not for this when it is only 3 centimeters. Don't nebulize whenever you see a high plateau if the trans airway pressure is less than 8-9. Understood?
Okay. Sir, how to check trans airway pressure?
You just do a plateau. The difference between peak and plateau is trans airway pressure, isn't it?
Okay, sir. Okay.
I showed you a diagram also that this part is contributed by the airway.
Okay, sir.
The difference between PIP and plateau is the trans airway pressure. Understood?
Okay, sir. Okay.
Right.
Understood.
This is another case. You tell me. One more doctor was willing to come and take up the question. Okay, Arjun, we'll go with you. Dr. Saneesh will catch hold of somebody else. See, this is a ERDS patient, 8 ml tidal volume, PEEP of 14, 100% FiO2, IE ratio 1:2, 20 rate, peak pressures are 38. Very high, no?
Very high peak airway pressure, sir. P plat is also very high.
High. ABG is showing 7.9 and PCO2 of 58. I do a inspiratory hold.
Okay.
So now P plat is that much. So what is the trans airway pressure? Only 6 centimeters. Do you want to nebulize?
Yes, sir. It is obstructive phenomena. So we have to nebulize.
Why? See, the peak pressure is only 38 and plateau is 32. What is the difference?
So 6, sir. 6.
6 is not around 8 centimeters you require to push the air, isn't it? That is the normal resistance, isn't it? On a ventilated patient, what is the normal resistance? 8 to 10 centimeters.
Yes, sir.
Then it is only 6. So
sir, then we have to decrease the tidal volume.
No, that is apart. Then why did you say nebulization? That is my point. You didn't analyze properly, isn't it?
Yes, sir. Yes, sir.
Yeah, remember, you should not do this mistake again.
Yes, sir.
So driving pressure is 18, plateau pressure is 32, tidal volume is too much, isn't it? 8 ml is
yes, sir.
So what do you do?
Sir. Decrease the tidal volume and increase the respiratory rate.
The rate you need not go initially because PCO2 and pH are reasonably acceptable as of now. So you just increase this and try to control the patient. Unless the patient has a low blood pressure, don't try to change this. Remember this, whenever you increase the rate, number of times the volume goes into the lung is more. See, if you beat something with a hammer 10 times and if you beat a coconut with a hammer 20 times, which will break faster?
20 times.
The same thing happens to the lung also. So never ever try to increase the rate if your carbon dioxide and pH are within normal. Okay?
Okay, sir. Okay, sir.
Okay. So, as you said, reduce the tidal volume 7 to 6 and again it has improved. When you come in the next morning, your peak is 33 and plateau is 28. What is your indication? What is your what do you imply?
Still the pressures are high, sir. We have to get down.
The plateau is 28 now.
P plat is normal, sir. It's fine.
So what is your indication that your lung is improving or not?
It's improving.
It's improving, sir.
So you don't require a ABG or X-ray, isn't it, to tell that lung is improving?
No, sir. It's not required. You can just see the scalars and decide.
That is what I'm trying to drive home the point. The information is available. Just don't do ABG and X-ray for everybody. You can analyze how your lung is behaving, how your airways are behaving without doing all that. Because we are in a situation where we may not be able to get anything if the COVID surge comes, isn't it? So you have to know, even for a normal patient also in a ICU, you don't require to do when you see this in your patient.
Okay.
So in a plateau, in a pressure modes, how do you do the plateau pressure? See, this is how the plateau pressure is. The PEEP with the pressure control above PEEP, 18 plus 5, 23 should be your plateau pressure. The addition of the pressure that the patient is getting is how much? P plus pressure control, isn't it?
Yes, sir.
In a pressure control, the addition of pressures, 2 pressures will be your plateau pressure. You remember that. Okay. It is that way most of the times because they say when there is no flow just before expiration, the pressure correlates to the plateau pressure. But in rare instances, when there is increased resistance and a very short inspiratory time flow may be still present. You can apply inspiratory hold even in pressure modes, and the pressure may be slightly less than what you estimated here. But for all the junior colleagues, I would say when you add up pressure control and PEEP, that is your plateau pressure. You can remember that. The pressure that you have set for delivering the tidal volume and your PEEP, when you add together, that is the pressure that you are applying to the lung, and that is your plateau pressure. You remember that. So auto-peep, when you want to estimate auto-peep, then you have to put an expiratory hold. So what is auto-peep? See, when the patient starts keeping too much volume in the lung because of the obstruction or a bronchospasm, air doesn't come up, air doesn't come out, and the pressure increases. So the baseline shifts. See, the lung starts operating from here, and you have put a trigger of -1 centimeters, and there is an auto-peep of 5 centimeters. Now, how much has the patient has to generate to reach this point? Arjun is muted. Okay. So this requires 6 centimeters. Now the patient's trigger becomes 6 centimeters. This is the reason why there will be a lot of missed breaths. You see, the patient has done only -1 centimeter, so he will not get the breath. Then again, he has done another 6 centimeters, he'll get a breath here. So there will be a lot of missed breaths. So a lot of missed breaths occur because this is what happens at the ventilator doesn't know this. Ventilator doesn't know this. So when it doesn't touch this point, then it doesn't sense that the patient requires a breath, and it doesn't give a breath. So see, there are so many breaths which are not being supported. There, see, the triggering is not reaching, and the patient doesn't get breaths. This leads to a lot of increased work of breathing. Estimation of auto-peep is very easy. You just have to cut down the peep what you have said, and then just give in a passive patient, say expiratory hold. You just give an expiratory hold of 3 to 5 seconds, then the pressure goes up. This is the auto-peep. If the auto-peep comes as 10, 80% of the 10 is the peep that you have to set up. So expiratory hold is done for estimating auto-peep. Before estimating a auto-peep, the set peep has to be made into 0. And then you put an expiratory hold of 3 to 4 seconds or 2 to 3 seconds. You can keep for both the maneuvers 1 to 2 seconds, or for this 2 to 3 seconds is fine. Then the pressure starts rising up, and then you get a auto-peep. This auto-peep, if it is measured, the ventilator will display. If it is 10 centimeters, 80% of that is what the patient requires. You can also look by looking at the volume. See, once this is the expiratory volume is getting around 300 ml. Now I put a expiratory hold here, and this expiratory hold can be for a very long time, 30 to 50 seconds. Then 700 ml has come out. So there is a extra of 400 ml of trapped volume that has come out. See, we used to squeeze the patient sometimes physically to get disconnecting from the ventilator. This is the reason why there will be a lot of trapped volume. This also can be estimated by expiratory hold by looking at volume versus time scalars. This is volume versus time scalar, not the pressure scalar. You remember that. So volume, as I've said, when you talk of volume, this will be tidal volume, this will be TI, and this will be TI. Only one thing that you can analyze is this. If this expiratory limb doesn't touch the baseline, there is a loss of volume. This is air leak. This is air leak. This is the only thing that you can make out with this. And just 2 more slides. Loop. I'll not discuss loop. Some loop discussion will happen during ARDS. I don't want to confuse you guys. This is the inspiratory limb. This is the expiratory limb. I have said that all loops. This is the pressure and this is volume. We have combined 2. And I have said volume should always be there because this is the essence of ventilation. So there can be only 2 types of loops: pressure volume loop or flow volume loop. This is a pressure volume loop. This is the inspiratory limb. This is the expiratory limb. As I have said, it has to come back to the point of origin. So now this becomes PIP and this becomes tidal volume, because we have combined both. There we were seeing separately. Now this is PIP and this is the tidal volume. In a pressure mode, what we are doing, we are fixing this. We are telling to the ventilator that the ventilator, the volume cannot, the pressure cannot cross beyond this. So when the lung becomes stiff, this will start going like this. This will start going like this. The volume will start coming in a pressure modes. Because this is fixed, this line cannot move, the volume changes. Volume changes. In volume modes, this is fixed, this cannot change. This will be pushed. If the lung is stiff, the pressure changes. This also can be explained by looking at the pressure volume loops. This is another representation just to tell you these were the pressure volume loops were used to understand or explain the pressure ARDS ventilation. See, ARDS ventilation, if you don't set PEEP, this is lung collapses for every breath. And if you have too much volume, there will be over distension. So if you have just around 6 to 8 ml and good amount of PEEP, then ventilation occurs between these two portions. Lung at the end of inspiration, it will be like this. At the end of expiration, it will be like this. The lung doesn't, if you don't give adequate PEEP, then the lung starts becoming from here to here. This is what is called as atelectotrauma. And this is what is called as a volume trauma. And when the ventilation occurs between these two, then we say the tidal volume and PEEP is well set. To understand the concept, this is very good. Then looking at flow versus volume loops, as I have said, because flow is there, there is a representation below the baseline. Whenever there is a representation below the baseline, it is always flow. Because flow is there and it is represented through this line. If you remember the flow scalar, this is peak inspiratory flow rate, this has to be peak expiratory flow rate. And this is volume, so this has to be FRC, and this has to be tidal volume. And the only thing that you can definitely find out is, as we have seen in flow versus time scalar also, if the expiratory limb shows obstructed flow or something is not allowing a smooth flow, it is always what? Airway secretions or waters in the circuit. Thank you. Any questions I'll address afterwards. There will be a question answer session. My colleague Dr. Saneesh will take over. Dr. Anoop had a TV interview today, and at 9 o'clock he has a meeting. So Dr. Saneesh me and Saneesh will be available. Any questions you can ask me the next 5 minutes, and then Dr. Saneesh will do the question answer session and 2-3 scenarios also.
Sir, in ARDS patients, when you decrease the tidal volume from 7 to 6 ml per kg, is there any minimum minute ventilation that you aim at to maintain?
Point is, it is like hypoventilation, isn't it? For all anesthetists, yes, and see, we are doing a permissive hypoventilation. So when you do hypoventilation, what increases?
The carbon dioxide buildup increases.
So there is a balance between acidosis, hypercarbia, and VI-LI, isn't it? See, these are the two things you have to balance. So that balancing has to be done. We will discuss that into ARDS. You just remember this much. As you asked, when you discuss there is hypoventilation, we will have to balance out.
Yes, sir.
I'll teach you when we go with ARDS ventilation. That
concept. So we have to determine that. Yes, sir. Yes.
Discuss it. It's a complicated issue, isn't it? Not to be.
Yes. Yes. Thank you, sir.
Yeah. Any more questions, Saneesh?
Sir, there was a question on how to identify auto-peep on flow volume loops.
Yeah, I'll show once again.
Sir, I have one more question.
Yeah.
Some ventilators do show that they give the values of PEEP and auto-peep. So can we go by that, or?
No,
like
when you put an inspiratory hold only, it gives. You have to make the PEEP 0, or else if you have set a PEEP of 5 and the baseline is starting from 8, which is
so
visible.
Is the auto-peep.
That,
yes.
Yeah. But actually determine, you have to do that procedure. But what it shows should make you aware that something is happening. See, this is what you see.
Thank you.
When the expiratory limb doesn't touch the baseline, there is volume still being bought out and the inspiration is set in. So this leads to when volume stays back in a closed space, alveoli, pressure increases. That is what we call it as auto-peep. Then when there is auto-peep, when the alveolar pressure is more, it requires more pressure from the patient has to generate more pressure to push the air in. Because as we have discussed yesterday, air only goes when there is a pressure difference. That is the reason why patient starts breathing with all his accessory muscles. I hope you understand. When volume stays back in the lung, you just remember, I have told you alveoli is a cul-de-sac. So more volume, so more pressure. So during inspiration, more pressure difference has to be created. That is the reason why patients get so ventilate with so much of effort and get tired. Then the carbon dioxide starts going up. This is the scalar, flow versus time scalar. This is how you identify there is auto-peep.
So there was a query on how to reduce air trapping, auto-peep.
We will discuss that in
COPD
class. But basically, IE ratio can be increased. There is one case scenario Dr. Saneesh will discuss. Nebulization, suctioning, IE ratio, decrease in tidal volume, decrease in respiratory rate. These are the things you can do to reduce the auto-peep. Most probably, if it is there is a spasm, medical management is this mainstay. Then you can control the IE ratio if the patient is paralyzed. If the patient is not paralyzed on a pressure support, you have to change the expiratory sensitivity and the rise time. This is the summary. You got my point. If the patient is paralyzed, you can change the IE ratio. If the patient is on pressure support, how to shorten the inspiratory time? By shifting the expiratory trigger sensitivity from 25% to, I'll go to that slide, we'll see, wait. I'll go to that slide and see. See, the inspiratory time is long. I cannot change the IE ratio. I can shorten the inspiratory time by changing the expiratory trigger sensitivity. See what I have changed here. From 25%, I have changed to 52. Look at the inspiratory time here and look at the inspiratory time. The expiratory time is much larger here, which was probably 1:2 has become 1:3.5. Probably the carbon dioxide and the auto-peep both will come down. And trigger, don't forget the trigger is wrong here. Trigger, remember 2, 2, 2, 1 to 2. Any more questions?
Sir, I think many people practice like if patient is on pressure support mode and tachypneic, they try to increase the flow trigger and kill the breathing efforts. Actually, we are doing more damage. Either the patient is not ready for a pressure support trial, or we have to do correction of the primary pathology, right, sir?
That is the worst unscientific, unphysiological thing you can do. What you have done is you have increased the trigger to 5. What happens is the ventilator will show less number of breaths, but the patient will be, his diaphragm will start contracting more and more. So as I have said yesterday, the work of breathing on a ventilator is much more than it would be without the ventilator. That's the most unphysiological thing you can do. Should never do it. As Saneesh said, you have to nebulize, change the IE ratio, sedate, whatever it is, or change the mode, but never ever change the trigger. You will be happy for the ventilator, not for the patient. The worst thing you can do on a patient. I think we'll go with Saneesh.
Sir, one more thing, like can pneumothorax be identified by scalars?
Any rise in peak pressures, because one lung is collapsed, all the air is going to the other lung, peak pressures will shoot. So you know something is going wrong. Then if you look at the lung and you auscultate, probably you will find out. It will say something is wrong. Then clinical application, or if the right side of the chest is not moving, then you may get an X-ray, but it will definitely indicate with rise in peak pressures.
Same with the tube block and endobronchial tube displacement.
Yes, everything, the peak pressures go up. We'll get into that with troubleshooting and alarms. We'll come back. But those are the ways that your mind has to start working now. What happens when there is pneumothorax? Peak pressures go up. Then it is for you to ascertain why peak pressures are up. Then As you said, tube block, peak pressures go up. Then the expiratory tidal volume will be very low. So then you will know, isn't it? Something is not coming out. There should be a tube block. You can deduct. We will come to that in case scenarios.
Basically,
Go
good thing with our modern ventilators are they give all the scalars and loops, so that if your mind knows, your eyes will pick up. So lots of graphical data and numerical data will be there on your screen. The moment you start identifying or picking clues from those screens, you can do justice to the patient and probably take corrective action at a faster rate.
No, you are always looking at airways and alveoli on those lines. That is the take-home message. You are not just looking lines. You are seeing what is the pressure the volume is generating in the alveoli. You are looking at what is the pressure each tidal volume is getting by looking at the driving pressure. By looking at the difference between peak airway pressure and the plateau pressure, you know how much is the pressure required to push the volume through the airways. So much of information is available. You don't require to do anything other than learning this science and ventilating the patients more scientifically. I think we'll go, Saneesh, with your presentation. If anything is there, we will answer in the end.
Yeah. What we are planning is there are enough queries regarding particular topics. We'll keep addressing that as we come to the scenarios. Okay. So you will get more chance to put your opinion. Sir, my slides are visible now, sir?
Yeah, it's visible to me.
Okay, fine. So who is volunteering for the first case? Dr. Vijay Mohan, you are with us?
You have to unmute, Vijay.
Dr. Vijay Mohan. Dr. Shweta. No, Dr. Vijay Mohan, you are with us. Okay. So these are some simple scenarios. Okay. So you look at this pressure versus time scalar, and can you identify what is wrong here? What you pick up from this part? Hello?
I think there is some dead space.
Pardon? Hello? Dr. Vijay Mohan, you are not.
Hello?
Yeah, please go ahead.
Yeah. I think there is some dead space. Air trapping.
No, actually this pressure curve is taking a dip here, and then the breath cycle starts.
This is the triggering part.
Okay. So this is the triggering part. Okay. So when patient triggers, basically the pressure baseline, patient pulls down towards negative side or towards the baseline, and the ventilator will sense it as a trigger. Okay.
Yeah.
So what happens is here the trigger setting is too much. They have set probably a 5 centimeter of water. So patient is struggling to get a breath. Okay. Now you change the trigger setting to 2. Now that additional effort, the wasted work of breathing is not there. Okay. So the moment the trigger comes to 2, then breath cycle gets initiated. Okay. Did you get the point?
Yeah, I got it.
Okay. So usual practice, as we mentioned before, is to keep higher trigger settings so that the breath won't be triggered, so that we'll get the respiratory rate reduced. So that is not the right thing. You correct the primary thing, because ventilator is just a supportive therapy. It's not going to cure the patient's neurological status or respiratory status. What we can do is we can avoid damage to the lungs, or you should not increase the stress to the patient. Okay, so you give a trigger setting maximum 1 to 2 centimeters of water. Okay.
Okay.
Fine. So this flow versus time scalar, what you can pick up now, you can see one breath, because as Sir has mentioned there is a positive swing and a negative swing. Okay. So positive swing happens in one direction, exhalation happens in the opposite direction. That's why it's plotted in the negative side. So what you can identify in this graphic?
Auto-peep, sir.
Okay, Dr. Shweta. Okay, fine. Auto-peep, why do you say it's auto-peep?
It doesn't reach the baseline, sir.
Okay, basically there is
and there is air trapping. Yeah.
Air trapping.
Air
Okay.
trapping.
Okay.
Yes.
So, and the next side, what you can find is?
It's not there now.
It's not
There's
there.
no air trapping.
It's reaching the baseline. Okay. So
Yes.
when you look into the screen and find this happening, then probably you can try quantitating the auto peep and probably supplement 80% of the intrinsic peep. Okay. There are different terminologies.
Okay.
Auto peep, air trapping, intrinsic peep and all. Fine.
Yes.
So
yes.
this clue you can easily pick from the flow versus time scalar.
Yes, sir.
Okay. So there were lots of queries regarding auto-peep. This is volume versus time. So what you can see here, this volume builds up during inspiration and then expiration, it comes down. Okay. Then what happens with this breath cycle? Shweta, you can comment. Shweta, you are with us?
Sir, I don't know. I don't know the answer.
Sir, the expiration has become less time for expiration.
Oh, you are talking of volume.
Volume.
Whole volume is decreased. Nothing. Some volume has not come back. So it has either some air leak or being retained. It can be both.
Okay. So we lose some air. Okay. We are leaking it somewhere, either inside or outside. So what do you do next when you find a graph scalar like this on your screen?
Check for leaks, sir.
No, where do you check the leak?
Commonest place.
Cuff.
Yes. Or disconnection somewhere, isn't it?
Yeah.
Circuit
Disconnection or cuff. Yeah.
Okay. So it's a good practice to sort out from maybe one direction: patient, circuit, ventilator. So 3 parts you can segregate and maybe sequentially you can check. Okay. Fine. So who is volunteering for next one? Dr. Lakshmi Narayan.
What loop is this?
Dr. Lakshmi Narayan.
Dr. Lakshmi Narayan, what loop is this?
1 minute. 1 minute. Dr. Lakshmi Narayan is allowed to talk now. You can unmute and talk.
Hello, sir.
Hello. Hi.
Hi, sir.
Slide went one ahead.
One minute.
Slide,
1
Saneesh.
minute. One minute. Yeah.
Not visible, Saneesh.
One minute. I'm changing the slides now.
Yeah.
Is it visible now, sir?
Yeah, it's visible.
Nice. Okay. This we have discussed, and this one, flow versus volume, flow volume loop. Dr. Lakshmi Narayan.
This is the flow versus the volume loop.
Okay. So you can commenting on that. So red curve. What did you find? No, sorry. It keeps on moving. Okay, here. So the white flow volume loop was the normal. Now the red one. What's your comment on this?
There is a decrease in the peak expiratory flow rate, sir, actually.
Okay, fine.
There can be any obstruction, so we can do suctioning or bronchodilator we can give actually.
Yeah, correct.
Okay, fine. So that's an excellent answer. So from this flow volume loop, I think some ventilators will allow you to retain a controlled flow volume loop also, so you can find out. Otherwise, you have to go to the trend and find out what is the trend in the peak expiratory flow rate. So the reduction in the peak expiratory flow rate says there is expiratory flow limitation, which happens probably in COPD or acute bronchospasm. And this scooped out appearance is also very characteristic because exhalation happens against an increased resistance. Okay, so what we can do to this particular patient is, from ventilator end it's different, from patient end we can give bronchodilators and relax the bronchospasm so that this scooped out appearance will disappear and the peak expiratory flow rate also will normalize. Okay, fine, clear? So whenever you are looking at the flow volume loop, you when patient is having a spasm, you can pick up all these clues. Okay, fine. So now who is answering this? Dr. Lakshmi, you can continue.
Yes, sir.
Okay, fine. So you can comment on this. What all things you can pick up from this scalar? There is a pressure versus time, flow versus time, and volume versus time.
Sir, in the first flow versus time, we can find out the mode actually, sir.
Okay.
First one is the volume control mode, sir.
Okay. Why do you say it's volume control mode?
Because it is a square in shape, sir, actually.
Okay, square wave pattern. Yes, good.
Second one is the pressure support mode.
No, we'll finish with the first one and go. Okay.
Okay.
So the pressure tracing, what you can find?
There is an inspiratory phase and an expiratory phase.
Yeah, fine. Okay. So what's the trend? It begins with a negative deflection. Okay, deflection down the baseline. So that means who is triggering?
Patient is triggering, sir.
Patient is triggering that breath cycle. Okay. Then the pressure gradually builds up to the peak and then drops off during exhalation.
Exhalation.
Okay, clear?
Yes, sir. Yeah.
So that pattern also we find in a volume control breath, and this one says that patient is allowed to trigger, says it's a
SIMV mode, sir.
It's a assisted mode, assisted breath. Okay, so we'll come to that later. Okay, this is an assisted volume control breath.
Control mode.
Okay, volume gradually picks up and then goes to the exhalation. You can see my mouse pointer.
Yes, sir.
Okay, fine. So now we'll in the exhalation we find the peak expiratory flow rate. We don't know it's high or low, but then it goes back to the baseline. Fine.
Yes, sir.
So now coming to the second breath. So who has started the second breath?
Patient has started the
patient
second.
has triggered. Okay. The triggering is by the patient. Fine?
Yes, sir.
Okay. Then what happens? Patient has triggered. And if you see the flow versus time, what you can find?
It is an pressure support mode, sir. Since
it's a pressure support mode because this is not touching the baseline.
Touching the baseline.
Before touching the baseline, say at 25% ETS, expiratory trigger sensitivity, it is cycling into the exhalation. Okay. So the volume generated is less and the set pressure support level is attained in this breath cycle. Clear?
Yes, sir.
So this is all in the background of a PEEP or a continuous positive airway pressure. Our baseline is actually raised to this value. This value is set as the PEEP. Clear? So now we have an assisted volume control breath and a pressure support. Okay. Now we come to the third breath cycle.
This is an pressure controlled ventilation, sir.
This one? Why
this is also
pressure control?
This is also an volume controlled.
Volume control. It looks volume like control square wave pattern only, right?
Yes, sir.
Okay. Again, it's triggered by the
patient.
The pressure reaches the peak and then falls off. So this is again a volume control. But assisted mode. Okay. Mandatory breath. What will happen? There is no trigger. Once the set time reaches, the machine will deliver the breaths. Okay, so what mode do you think fits into this graphic?
Mostly it is an SIMV mode, sir.
SAME volume control with
Volume.
this one. So we have given some
Pressure
additional
support.
help. Yeah. So SAME volume control with the pressure support.
Pressure support mode.
Okay. So from this one single screen, we can identify what mode it is and what all features are. We can go into the background of this mode and how it works. So clear? So this
Yes, sir.
is a trigger. That means this is an assisted breath. Otherwise, it would have been a mandatory breath. So SAME incorporates both assisted breaths and mandatory breaths. Okay. Because this is square wave, it is volume controlled. If it is a decelerating pattern,
It's a
it would
pressure
have been a
support.
pressure control mode. Okay.
Pressure
Right now it's a square wave kind of thing and it's volume control. And the spontaneous breaths, are we offering help? That is what is mentioned as pressure support. Clear? Okay. Only in pressure support, this changeover from inspiration to exhalation occurs above the baseline, depending on how much ETS you are setting. So now we are clear about ETS, expiratory trigger sensitivity in pressure support.
Yes, sir.
Okay, fine. So may I have one more person volunteering for the next one? Thanks, Lakshmi.
Thank you, sir.
Okay, Dr. Melito. Yeah. Can you unmute and talk? Dr. Melito, you're with us?
Yes, sir.
Yeah,
Yes,
fine.
sir.
So I'll go to the next slide. Okay. So you have to pick up all the information what you can brief us with this graphic. We have a flow versus time, pressure versus time, volume versus time.
Okay, sir. This is starting with the flow. The first breath, it is a ventilator triggered breath. It's a control mode.
The first breath is there is a trigger, no?
It's
Whenever
a controlled mode in a decelerated one. So it's a pressure control.
Yeah, this is pressure control. Okay. So because this is flow is decelerating, okay, and it's touching the baseline, this looks like a pressure control flow trace. Okay. Then coming to the pressure tracing, you can find there is who initiated the breath.
There's a trigger.
There is a trigger.
Patient triggered the breath.
Yeah, you can identify the trigger. Okay, then what happens to the pressure tracing? Can you describe the pressure tracing? So pressure rises to the set value.
Yeah.
Okay, so this breath
It
cycle
is limited by the
set pressure. Clear? Then it holds on for some time till cycling occurs. Okay?
Yes.
Then what follows is the exhalation phase, expiration phase. Volume also you can see is gradually building towards the end, it reaches the maximum.
And then decelerate.
Okay, so the first breath is assisted pressure control breath. Clear?
Yes.
Okay, how about the second one?
The second one also is the same, sir.
It's the same. Again, during exhalation, you can find that it is touching back the baseline. So there is no question of air leak, air trapping. And the volume exhalation curve also goes back to the baseline. So there is no issue with the. If this curve is not touching the baseline, what is your inference?
If it is not touching the baseline, then there is some air trapping.
There is leak. No, I am speaking about the volume. Inspiratory volume is given and the curve is switching back to the baseline. No. So
there can be a leak. There can be an air leak.
There can be leak. Okay. So all this information you can pick from the screen.
Can be an air leak or an air trapping, sir.
Either way.
If
we are missing out
curve,
something because we have pushed in probably 500, only 400.
And we are not getting back.
Okay.
And we are not getting back the same amount there.
Yeah. So there is some missing. Then we have to do the troubleshooting. Okay. So here you can clearly see that the flow, decelerating flow touches the baseline. So it is time cycle. Clear?
Yes, sir.
Okay. Fine. Decelerating flow, changing from inspiration to exhalation, occurs after touching the baseline. So this is assist pressure control mode. Okay, because patient is triggering, these are assisted breath. Okay. Hello.
Yes, sir.
Yeah. Okay. So breaths, there can be different type. Mandatory means machine initiates, machine limits, machine cycles. Okay. Assisted means patient initiates, but either machine or patient can cycle. In fully spontaneous, patient starts, patient cycles, patient triggers, patient limits, patient cycles. Okay.
Yes, sir.
Clear? So pressure support,
Yes.
patient initiates, but it's limited by the pressure support, and then cycling depending on the flow trigger sensitivity. Okay. You're clear about it, or am I confusing you?
Oh, it's clear, sir.
Yeah. Okay. So you can take one more question if you don't mind. Okay.
Okay, sir.
So this is the scalars building up in front of you. So you can speak along.
Sir, the flow, there appears to be no trigger, so
No.
and
Here,
it's a
here you can
decelerating
find the
one.
trigger. Okay.
Trigger is
Yeah,
always
there is a trigger, sir.
pressure.
Trigger.
Told you with the flow just press upon you. Trigger should always be seen on the pressure mode.
Yeah.
Here I have
Pressure.
done this because to make you understand.
Okay. So next time onwards, we check for trigger in the pressure scalar. Okay. Fine. Comment on the flow versus time graph, please.
It's a decelerating graph,
Okay.
and it has, it has reached back to the baseline.
It doesn't touch the baseline, right? So it's
Yeah.
switching to expiration here.
Yeah. It's a after the flow has reached 25%, it has.
Yeah.
So it
So
could
it
be a
looks
support,
pressure support. Okay, pressure support. Excellent.
pressure support.
Okay. So what is
Cycling
the
is done by the
result in the pressure curve?
pressure curve.
There
It
is
shows
a
a trigger, sir.
Yes.
Trigger.
Then this is the set pressure level. The plateauing, the flat line, the horizontal part is the set pressure support level. Are you following?
And then there's
Like there is a trigger,
yeah,
then we reach the pressure support level, and once the trigger cycling occurs, then you switch over to the exhalation part. Yeah. So if you see the volume gradually builds up until cycling occurs. Till then, volume keeps building up. Okay. So if the volume built up is less and you want the patient to take in more volume, what you will do in the setting?
increase pressure support.
Yeah, you can simply increase the pressure support and see how much it works out. Okay. So regarding the second breath cycle again.
It's a decelerating breath cycle.
Yeah.
And
okay.
it is patient cycle.
Pardon?
Patient cycle.
It's patient trigger.
It's a patient cycle.
No, this is flow expiratory trigger sensitivity. Depending on that, it's cycling. Okay. Flow cycling occurs.
And
are you getting my point? So we have kept an expiratory trigger sensitivity maybe at 25%. So when the flow reaches 25%, the switchover from inspiration to expiration occurs. Okay. Again, looking at the pressure curve, initially there is a negative deflection. So that means patient is initiating or triggering. Okay. This part.
This is that is the limit where a set pressure support has been given to the patient. The flow remains constant until the cycling is happening. At the cycling point, there is flow decrease.
Okay, fine. Again, the volume, it's the same. So all three breath cycles are the same. So which mode it is now?
This is a pressure mode, pressure support mode.
Pressure support mode. Okay. Is there any CPAP?
No auto-peep.
No, I'm not telling you auto-peep. Is there any peep applied here?
No peep, sir.
No peep. We can find out from.
It comes back. Yeah, the pressure curve comes back to the baseline.
Yeah.
So
Okay.
there is
Okay.
no peep.
Yeah. Okay.
Not the place to look peep. You have to look it here. See, it is starting from the baseline. Peep is there. I told you all
Yeah.
pressure also starts.
Okay. If peep is there, this baseline will be elevated. Our graph will be slightly up. Okay. Fine. Again, you didn't find any auto peep. You didn't find any air leak also. Fine. Clear?
Yes.
Okay. Fine. Thank
Yes,
you.
sir.
Uh,
Thank you.
who is volunteering next? Kiran B. Patel.
Yes, sir.
Can you take the next question?
Yes, sir.
Okay, fine. So here we go. Okay, this is the scalar for you.
Yes, sir.
So can you comment on the breath cycles?
Yes, sir. The first graph shows the square, so it's a volume control, but there is no negative pressure in the pressure graph. So it's a mandatory. So it's a volume control ventilation mode.
Mandatory breath. Okay. Yeah. Can you find the other? Explain the other features. The pressure gradually fills up to a peak
Gradually fills
pressure.
up to the end of the inspiration, and then the exhalation cycle starts.
Okay.
And it reaches up to the baseline. So there is no air trapping. There is no leak as such there.
Fine. So what is this pressure called?
That is a peak inspiratory pressure.
Peak inspiratory pressure. Suppose it is 40 and you are interested to know the plateau pressure. How will you do that?
Then we have to press the inspiratory hold button and then check.
Okay, inspiratory hold button for 1 to 2 seconds.
And then check.
The machine will give you a value of a
The
plateau
real peak inspiratory pressure and the plateau pressure.
Okay. Then the difference between peak inspiratory pressure and the plateau pressure is
that is trans airway pressure that suggests the resistance in the airway.
Yeah. So if it is high, then what you have to do?
Then we have to give the bronchodilator to reduce the airway pressure.
Yeah. When you are doing the troubleshooting, make sure that you look at the patient, circuit, or ventilator. Okay. If there is any circuit king, ET tube king, also this this trans airway resistance will be more. Okay. So you have to make sure that there is no kinking.
Yeah.
So look at the best possibility. You auscultate chest. If there is any audible wheezes and all, then you institute bronchodilators. So troubleshooting includes a comprehensive view. You cannot ignore the machine. You cannot ignore the patient and the in-between interface circuit also. Okay.
Yeah.
Fine. What about the second breath cycle?
The second breath cycle also see the same square graph. So it's also a mandatory machine triggered control mode ventilation.
Okay, mandatory volume control breaths.
Yeah, the peak inspiratory pressure is same as like in the first graph, but the inspiratory time is somewhat shorter than the previous graph.
Okay.
The first graph.
Okay, so so we'll concentrate on this part. So basically, the idea is to make you understand what is pressure peak, plateau pressure, and the trans airway pressure.
Trans airway pressure.
Okay, fine. So mandatory breath square without patient triggering.
Patient triggering.
Okay, this is a control mode volume targeted ventilation. So the preset tidal volume is delivered and volume cycling occurs. Clear?
Yeah.
Okay. So if you don't mind, we can stay with us for the first scenario. Okay. So listen to the scenario because it's a comprehensive view. A 35-year-old farmer admitted with organophosphorus poisoning, saturating 80% on 15 liters of oxygen on non-rebreathing mask. It's a chronic smoker. On examination, you find bilateral crepes and oral secretions. You know, organophosphorus, you will get a lot of secretions, sweating.
Lot of secretions due to the cholinergic predominance.
So patient neurologically is drowsy, is very tachypneic, 35 breaths per minute, increased workup breathing. You can find the accessory muscles also working. So, and blood pressure of 150/60, heart rate tachycardic, 134 per minute. Would you intubate or attempt non-invasive ventilation?
Looking to the history, sir, that the saturation is 80% with the 50 liters of oxygen on the non-breathing max with patient is over. Also, the history of chronic smoker and patient is drowsy. So, as the patient is chronic smoker, then I would like to put on the non-invasive mode of ventilation. But the looking to the history, patient is drowsy also and having saturation 80%. So I like to intubate the patient.
Okay. Not only that,
initially,
his sensorium is low.
yeah,
Okay. When there is enough oral secretions, you will have more chance of aspiration when you go in for a non-invasive ventilation.
yeah.
Okay. So your idea is to proceed with invasive mechanical ventilation. Agreed. So which
Yeah.
mode? We'll concentrate on ventilation.
So the blood patient's respiratory is 35 and saturation is 80%, and there is a increased work of breathing. So first I like to put patient on volume pressure control ventilation.
Okay. What is your key concern?
Because sir, there is oral secretion and there is a chronic airway obstruction because of the chronic smoking. So if I put in the volume control mode, then there will be chances of increase in the peak inspiratory pressure and all this. So to avoid this and to generate the tidal volume, I prefer to put the patient on pressure control ventilation. So that
no, that's only one school of thought. Like you anticipate something, you may not know whether it will happen or not. Okay.
Yeah.
So otherwise, you have an ideal body weight calculated and go for a volume control mode initially. Targeting 8 mL per kg tidal volume. Because patient is hypoxemic, you start with an FaO2 of 100%. Okay. Initially, see, unless we find more clues regarding his chronic smoker status, emphysematous changes and all, you initially go with a 1:2 IE ratio. And because the patient is already tachypneic, you cannot simply come down to breath rate of 12, 14 and all. Okay. So you have to start at a higher respiratory rate, set rate.
And then after thorough suctioning and all this, we have to look after for 5-10 minutes or half an hour or 1 hour, and then we decide to change the mode.
Will keep on coming, organophosphorus, because we have to counteract the secretions part. Okay. So first one, we'll check what? First pressure you are checking in the monitor will be peak pressure. Okay. So this is a tracing for you.
Yes.
Okay. Suppose the peak pressures are 45. What do you do next?
Sir, first I will reduce the tidal volume, and by simultaneously do the thorough suctioning.
That is one thing. We'll go a little systematically, because we have seen a peak pressure of 45. Now, what are you interested to know?
To reduce the obstruction, inspiratory airway obstruction, by doing the thorough suctioning and
obstruction. How do you know lung is good and there is only trans airway resistance?
Yeah, that is by reducing the tidal volume.
No, my question is, how do you make out whether there is an airway problem or lung problem per se?
Do the inspiratory hold.
Yes, and
do a P flat.
Yeah,
do a P flat.
Okay, so you find out the plateau pressure.
Plateau
do
pressure.
the inspiratory hold. That is the message that we want to convey. Okay.
Okay.
Do an inspiratory hold of 1 to 2 seconds. Find out what is the plateau pressure. Okay, then you can differentiate whether it's an airway problem
or it's a problem of alveoli.
Okay, then depending on our finding, these are objective things. Okay, then you can take the next step. Suppose I am telling you are getting a plateau pressure of 30 centimeters of water.
Yes.
Okay, so we have already kept a PEEP of 5. So what's the driving pressure now?
Then 25.
25.
Yes.
Okay, so driving pressure 25 is required. That means lung compliance is
low.
Not good. Okay, low.
Not good. Yes.
Okay. So even the lung is filled with secretions. The compliance is low. So that
also
message, if you get a plateau pressure of 30.
30.
Okay. Suppose the plateau pressure was something like 24. only your peak pressures are 45, then what's your inference?
Then the trans-airway pressure is high because it's a PIP minus P plate is equal to trans-airway pressure.
Okay.
So that means there is a obstruction at the resistance or in the airway. So we have to give some nebulization or etc. to reduce to use the bronchodilator.
Fine.
And
so
reduce
here,
the airway
if
resistance.
you take the peak, pressure peak as 45 and the plateau pressure of 30, still the trans-airway pressure
yeah, it's more than 10, 8 to 10. So definitely
now
we'll to
what you
reduce the
infer,
trans-airway pressure.
the problem is not only with the airway, but also with the lung. Okay, so this is the idea of using the plateau pressure. So you just do the inspiratory hold for 1 to 2 seconds, then the whole scenario unfolds before you. Okay, suppose the plateau pressure was low, only the airway pressure is fine, then you need to tackle only the airway resistance.
Airway resistance.
Now you are getting a message that the lung is filled with secretions. That is why there is compliance issue. Okay, so this is the beauty of looking at the scalars on your ventilator screen.
Sir, I have a small doubt.
Yeah. Please
Hello,
go
sir.
ahead. Yes.
Sir, once the peak airway pressure went to 45 centimeters of water, then you do a P plat and do an inspiratory hold for 1 to 2 seconds, and then you do then you calculate the P plat minus the peak, and then you see the driving pressure, sir. Am I correct?
Yeah. So even otherwise, by that time, machine will tell you what is the compliance. You will get the lung compliance straight away.
So, how do we know if the compliance is a problem or is the airway pressures are the problem? How do you get to know, sir? Following the P plat.
That's the point. Once the P plat is here, that means this difference P pressure peak and P plat is 15, which says there is an airway resistance issue. Okay, suppose the P plat was here somewhere around 20. Okay. And the pressure peak is 45, then the difference is 25, all accounted by the airway resistance. Your lung is fine, lung is still not wet. Okay, lung compliance is good. So two scenarios are different. Here actually with the plateau pressure of 30 and with the peak pressure of 45 means we have to tackle airway resistance as well as lung issue. Suppose the P plateau was somewhere around 20s, driving pressure of 15, that's fine. So lung is fine, only airway pressure, airway resistance you have to tackle. So that is the making point. Once you get the plateau pressure, then the scenario unfolds before you.
So you have to know, we have to know whether it's the resistance problem or is the compliance problem.
Yeah. It is not about blindly giving nebulization. Okay. Blindly going for bronchodilation may not work always. Because if
sir, when should we think of there is a compliance problem is what I wanted to know, sir.
No, whenever see, basically, roughly speaking, we target a plateau pressure of 30. Okay, whenever peak pressure is below 30, you are not much worried about the lung compliance. But if the peak pressure has gone up, definitely make sure you find the culprit, whether it is airway resistance or lung. Or both.
Thank you.
Both. There are different possibilities, permutations, combinations. So only the airway problem, only the lung problem. Because suppose the difference between pressure peak and plateau pressure is only 4 or 5 or 8. Usually to account for the normal airway resistance, there will be a difference of roughly 5 to 8. Then, okay, you need not spend time with the bronchodilation and all. Then you know there is a pathology with the lung. Okay, lung will take on time to recover. Maybe you can start with other measures to dry up the lung faster rather than going ahead with the bronchodilators again and again. Patient is already tachycardic. So whatever you are doing, you can have a justification. This is like evidence. So you found that there is a trans-airway pressure problem, increased airway resistance. You can always start a bronchodilator or other secretion. Maybe do a suctioning, remove secretions, clear the ET tube of secretions, because this organophosphorus poisoning, this is bound to happen. No? When you clear the secretions, trans-airway pressure falls. Okay. So this is how you keep on setting this. Okay. So first you do empirical setting, then you get the information and then change your settings accordingly. It's not like you, this case, this is a setting, you forget about it and do the rounds next day. No, critical care always it's better to sit with the patient, see all the hemodynamic changes, watch all the changes in the ventilator, either graphic wise or numerical wise, and then according to the trend, you take decisions. So are you getting the point?
Yes, sir. I got it. Thank you.
Okay, fine. So how do you proceed now? We have to institute the lung drying measures like atropines, oxygens, and again to tackle for the increased resistance, you have to start nebulization. And for the time being, reduce the tidal volume to 6 to 7 mLs per kg, probably increasing the PEEP a little bit. Also will try to drive away the water from the lungs. So each measure you take, which should have an objective. Clear?
Yeah.
Fine. Okay. So who is taking the next case scenario? Dr. Arjun?
Yes, sir.
Okay, fine. So 40-year-old diabetic patient admitted with respiratory failure, again saturating only 85 on 15 liters of oxygen on non-rebreathing mask. Is also drowsy, tachypnic 35 per minute, increased work of breathing. Blood pressure is 90/60 only. Heart rate is 134 per minute. Would you intubate or go ahead with the non-invasive ventilation?
So patient is drowsy and hemodynamic compromise. So better to intubate.
Yeah, okay. So not much margin because patient is already drowsy, you lose the sensorium, you don't already hypoxemic, you don't get enough time to experiment, go with an NIV trial, I think. So we can go for a invasive mechanical ventilation. So what mode would you choose?
So we'll go with volume control mode with 7 ml per kg body weight tidal volume with FIO to 100%, IE ratio of 1:2, respiratory rate of 20 and PEEP of 6.
Okay, 6 is fine. Then we can upgrade it depending on the hemodynamics and all. Okay.
Yes.
So what do you look at? Peak pressure. So this is the graphic or scalar you found on your screen.
Okay.
Peak pressure is 22 centimeters of water. So what does it tell you?
Lung is good. Peak inspiratory pressure is within normal limit.
Okay. So peak pressure 22. What does it tell you?
Hello.
Hello. Yeah. Please go ahead.
Yes, sir. Peak pressure, sir.
Peak pressure is 22. What does it tell you?
Means the tidal volumes are low, so you have to increase the tidal volume and increase the respiratory
Other
rate.
way around, like peak pressure of 22 with a good enough tidal volume says your lung is good.
Yes, sir.
Okay, so you don't have to worry much about plateau pressure. Plateau pressure should be less than that. Anything less than 30 we'll take with both hands.
No, normally,
yes, sir.
In anesthesia, the peak pressure should be around 17,
25.
17, 18. That's what you remember. And plateau pressure of around 18, 19 is what you have to target in OTs. This we are looking at 6 lungs. So don't get confused when you are doing a normal anesthesia. Your peak pressure should be within 20 and plateau should be around 13, 14. When your peak pressures are less than 20, you don't require to look at your plateau.
Okay, sir.
Okay, so we may not require a high FiO2. Maybe transiently you have a good FiO2 and you can reduce it. So now I will think about another possibility when the peak pressure is 35.
If the peak pressure is 35, then do P flat, sir, and do a inspiratory hold for 1 to 2 seconds.
Okay, fine.
Check for the inspiratory hold and then.
Okay, inspiratory hold for 1 to 2 seconds. So what you found is plateau pressure is 31.
Still it is high.
No, we are thinking about a second scenario. Okay, we are deviating from the initial one. Suppose the peak pressure is 31 and the plateau pressure is 31. Peak pressure is 35. Plateau pressure is 31.
Okay, sir.
With a PEEP of 5.
Then his problem is at the lung level.
PEEP of 10, sorry.
Then it is the compliance problem, sir.
Yeah, so we have to look at something has gone wrong with the lung per se. So we are not happy with the compliance part of it. So driving pressure requirement is high. So we have to reduce the tidal volume.
Yes, sir.
Okay, initially we tried for a tidal volume of 7 mL per kg. Now you come down some more, and probably that margin you can use for PEEP because of hypoxemia. So we are discussing about separate scenario. First one was
reduce the tidal volume, increase the PEEPs.
Yeah. Fine.
Yes, sir.
So this happens in something like ARDS.
Yes, sir.
Okay.
Yes.
Sepsis. So we have to uptitrate PEEP, go for a reduced tidal volume. So initially what we have set is an empirical one. So once you know the compliance is bad, actually we are ventilating the full lung.
Yes. Here the resistance is normal, sir. The problem is with the compliance.
Yes. So you find the culprit not in the airways but in the lungs per se.
Yes.
Okay.
Yes.
Fine. So if the trans airway pressure is high, suppose in this case 35 versus suppose Plato is 21, then it requires medical therapy like nebulization. Okay, always you look for endobronchial tube placement, tube kinking and all, and do suctioning. Then still the airway resistance is trans airway pressure is high, then you start with the nebulization.
Yes, sir. Yes.
Can you take one more scenario?
Yes, sir.
Okay, fine. So scenario number 3, 60-year-old diabetic patient admitted to ICU, saturating 88% on 10 liters of oxygen, non-dry breathing mask, increased vocal breathing, tachypneic with a 35 breath rate. Blood pressure has dropped to 70 by over 40. And he's drowsy. Blood gas shows a pH of 7.35, SiO2 of 52. You have started on fluids vasopressor. So what do you do
Sir,
next?
first of all, because of hemodynamic compromise and drowsiness, intubate the patient first and put the patient on volume control mode of ventilation. And
if this guy is COPD, where is the COPD patient?
So there is a COPD element as well.
Once you give fluids and vasopressor, it improves a bit. It becomes a little more alert. Can you go with NIV?
Sorry, sir.
This guy
After
is
your, so please. So after your fluids and vasopressors, if sensorium is better and hemodynamics improves, would you go for an NIV or intubation?
Sir, if provided he improves, his drowsiness is fine, he is conscious oriented, then NIV for sure. If his drowsiness is the same and he is on vasopressors and hemodynamic compromise, better to intubate.
now okay. If he improves, we give NIV. And what are the symptoms of NIV?
Okay. So what will be your ventilator settings initially post
So
intubation?
ventilator settings will be volume control mode of ventilation with 7 ml per kg body weight with PEEP of 6, FiO2 of 100, 1:2 ratio of IE ratio, and PEEP of 6.
So this is a scalar you are getting. PEEP of 7.
Then the peak airway pressures are more, then do a P plat and do a inspiratory hold of 1 to 2 seconds and see the driving pressure. If the driving pressures are 15 centimeters, then it indicates it's the airway problem. Then you correct it with doing a nebulization.
Okay, fine. So once you find that there is an airway resistance issue, now that we have a COPD background also, so probably you can increase the exhalation expiratory time. Okay.
Yes. Increase the IE ratio, sir.
Yeah, IE ratio. So more of exhalation time. So more of time for squeezing out air or air CO2 washout. And you need not increase the respiratory rate. We'll come to that later when we discuss the other case scenarios. So we reduce the respiratory rate. Probably we'll settle with a 7 ml per kg of tidal volume. You start with the medical therapy. Okay, bronchodilators, steroids, antibiotics, whatever it's required to control the sepsis and hemodynamic control. So
Sure.
clear? So in this
Yes.
scenario, we found that there is a trans airway pressure is high. So we tackle the airway resistance issue.
Yes.
So what we are finding is a expiratory flow limitation.
Yes.
Okay. How about this case?
Yes. Shall I take it, sir?
Yeah, please.
Sir, with
60-year-old COPD patient
60-year-old.
admitted to ICU, 88% saturation on 5 liters of oxygen, increased work of breathing, respiratory rate 35, blood pressure 120/80, respiratory rate 35, Aussie, pH of 7.35, PCO2 52.
As you can try with the NIV, sir. As a patient is a little drowsy, it's better to intubate and ventilate.
Okay, fine. So eventually, maybe without NIV trial, suppose you have landed to decision on invasive ventilation. So how will you set the ventilator?
The initial ventilator settings will be volume control mode of ventilation with tidal volumes of 7 ml per kg body weight and pressure and FiO2 of 100% and I ratio of 1:2 and PEEP of 6 and respiratory rate of 20.
Okay, fine. In this scenario, our intensivist put PEEP of 8,
Volume control.
volume control 7 ml per kg, 100% FiO2, 1:2 I ratio, respiratory rate of 20. Okay, fine. So you this is the tracing. You find the plateau pressure as 22.
22. So here
Plateau pressure of 32. Sorry, plateau
plateau pressure of
32, PEEP
32
of 8.
8. So the driving pressure is coming up to 24. Then it is the a problem with the compliance, sir.
Okay.
The problem is with the lungs, not the airways.
Even with the airway also.
Airway also there is problem now.
Yeah,
Fine.
there are problems with the airway as well as the lung compliance.
26 is the difference. So not much problem with the airway resistance.
No, Saneesh, there is a mistake. This should be 32.
Pardon?
The
Plateau pressure 32.
This is a mistake.
32.
So driving pressure is normal because it is 22 minus 8 is equal to 14.
24.
Okay, so if the plateau pressure is 22, driving pressure is acceptable, right? Only 14 is the driving pressure.
Yeah, it's 14 only.
Okay. In that case, the difference between pressure peak and the plateau is 16.
There is a quite.
Okay. So we have to tackle the trans airway resistance. Fine.
Yes, sir.
If plateau is 32, then we have an issue with the compliance.
Okay.
Okay. Fine. Yeah. So this has already been shown. When you find a flow volume loop like this, what's your inference?
Sir, it may be because of secretions or it may be because of
obstruction in the airway anywhere during expiration.
No, this oscillating kind of expiratory curve.
secretions.
Or maybe because of water logging.
Yeah. Excellent. So these are the two possibilities you have to keep in mind. Airway secretions or water in the circuit when you have an HME in the circuit, and sometimes when you have a heated humidifier also, you'll find the circuit filled with water and oscillating along the breath cycle. So you will find the sawtooth appearance in the exhalation part of the flow volume loop. Okay, so clear? Any more doubts? We are here to clarify.
No, sir.
No, sir.
Sir, I finished with the scenarios.
Questions will for another 4-5 minutes. We'll take another close.
Yeah.
Hello, sir.
Yes, please. Go ahead.
Sir, actually, when we are ventilating during anesthesia, if the EtCO2 is increasing, means how to tackle, sir? Actually, will reduce the tidal volume as well as the rate, or how to set during that time, sir? Actually,
carbon dioxide, if it is increasing, one possibility is if there is spasm, then the peak pressures will go up, isn't it?
Yes.
So then you can know that it's because of the spasm that you can tackle it. You don't require to panic very much. But if there is some aspiration, then the peak goes up and plateau also goes up, then increasing PCO2 will be difficult. So whenever PCO2 goes up, check the PIP and plateau and look what is the problem. If it's a airway problem, it is easy to handle. If it is a alveolar problem, we are in trouble because probably it will be an aspiration. The other one is laparoscopy. Sometimes in laparoscopic
Yeah.
surgery, slightly go up. But that is not to be worried. That usually goes up 4, 5. That should not be worried. If it is alveolar problem, micro aspiration, then we are in trouble.
Any more doubts? I hope we had a good enough explanation of the scalars and loops. And from the very next time when you enter the ICU and a patient on mechanical ventilation, your eyes should be catching all these salient points. Okay, eyes don't see what mind doesn't know. Now that mind knows, eyes should pick up. Okay, it comes by practice. The moment you find a discrepancy, the tracing not touching the baseline, now you know what are the immediate possibilities and then act accordingly. Once you find a high peak pressure, plateau pressure, if it is not automatically given, go for an inspiratory hold. Then you figure out where exactly is the problem, where both sides you are going to tackle, then tackle accordingly. Fine. Then from tracing itself, when somebody else has set the did the setting and you are taking over, from the tracing itself, you should be able to understand which mode it is. Okay. You can pick up all the information when the patient is on pressure support mode. From the tracing itself, you try to practice to find out which mode it is and then verify with the screen or the other settings. Okay, once you keep practicing, this comes naturally. So picking up the secretions or water in the circuit from the flow volume loop comes easy. So now, even before auscultating, when you can put a flow volume loop on the screen, you can identify the drop in peak expiratory pressure, the scooping out pattern. You can find that there is bronchospasm element. Okay, so you can use this knowledge to the best effect. So once you keep practicing it, this comes more easy. Okay, so we'll be sharing these teaching materials through our website. Okay, you can download this, revise this. I think today's session we have successfully managed to get YouTube live, and the YouTube link has been shared in our Facebook page also, so that you can go through these sessions, these questions, these scalars, these graphics again and again, and for your thorough understanding. So any more doubts you have, you can feel free to post it in our Facebook page or communicate to us through our regular means of communication. So next mechanical ventilation session, we'll address those issues as well. So depending on your feedback, your requirement, we are modifying the, ultimately you should benefit the maximum. So we are giving you the maximum opportunity to interact and come out with the answers. So we'll discuss. That's how we have planned these modules.
Saneesh, they're asking about the Facebook page and web address. Just
Yeah, Facebook, you can always search for @webinar campus. You can.
Sir, when is the next session?
Mechanical ventilation next session will be on next Monday. So
Monday.
module 3, Mondays and Tuesdays we'll have mechanical ventilation. Dr. Chandrasekhar will be with us. Okay. So you can put all your queries, suggestions. If you want to put more subtopics into our discussion, you can give your suggestions also through our Facebook page @webinar campus in Facebook. Okay. YouTube channel also there is. We have opened a YouTube channel, Webinar Campus. So once you can log into that Facebook page and like the page and or subscribe in our YouTube channel, you will keep on getting the notifications whenever we upload the teaching material. or upload the offline versions of the videos whenever possible. We'll be notifying through these platforms.
Thank you.
Okay, sir, we can conclude, sir.
Yeah. See you all on next.
Okay, looking forward to meet you on next Monday, sir. Module 3 of mechanical ventilation. Thank you all for your wonderful participation and your suggestions, comments, and answers. We enjoyed doing this session for you. Hope you also enjoyed. It's goodbye from us. Thank you. Thank you, sir.